you. In the name of the ESSO Education and Training Committee, I'm pleased to welcome you for this webinar, treating of non-cutaneous melanoma. We have beautiful panels tonight, and we are going to start immediately with my colleague, Dr. Toufic Maalouf, who is an ophthalmologic surgeon. He is going to talk about ophthalmologic melanoma. You can speak, Toufic. Thank you very much to be there.
Thank you. Thank you. Let me share. So, is it okay for you?
Perfect.
Thank you. I'm very happy to be with you this evening, and thanks for the invitation. My topics today is about ophthalmologic melanoma, and I don't have any conflict of interest. And before developing melanomas of the conjunctiva and UV, it seems useful to say a few words about a frequent differential diagnosis, which is a common pathology, and I mean conjunctival nevus. Conjunctival nevi are very common. It's a benign tumor, but can sometimes be frightening. Indeed, the nevus of the conjunctiva, as seen in this slide, is a well-defined tumor formed of melanocytic cells without cytonuclear atypia. In children, rarely pigmented, but this pigmentation will appear in teenagers and will frighten parents, but malignant transformation is rare, and the presence of inclusion cysts, as we can see, I don't know if it is possible to see it in here, but it's in favor of the benign nature of the lesion. No treatment is necessary, but a simple monitoring and photographic documentation are sufficient for the conjunctival nevus. The second diagnosis is the ethnic melanosis. So-called ethnic melanosis, ethnic pigmented lesions are seen in pigmented patients. We always have excessive pigmentation, but without any nuclear atypia. Both eyes are usually affected asymmetrically, and pigmentations are usually predominating at the limbus. Malignant transformation is very, very rare. Then we arrive to a differential diagnosis to mention, which is the primary acquired melanosis. The primary acquired melanosis, we have different terms. We have in this case shows abnormal melanocyte proliferation with a variable degree of cellular atypia, which remains intraepithelial. This melanosis is visible around the age of 40. We speak of salt and pepper sprinkling, especially in the cul-de-sac, often one-sided, with the possibility of malignant transformation. There is classification according to the importance of intraepithelial atypia, and there's no therapeutic consensus for the primary acquired melanosis. Biopsies are possible. Local therapy, including mitomycin drops, or surgical excision with amniotic membrane graft will be discussed. And for the small lesion, observation will be sufficient. For the others, we can use mitomycin drops at 0.04% concentrations, many cycles, under a strict ophthalmologic control because of the side effects of the mitomycin drops. Here you can have an example before and after using mitomycin drops. The true conjunctival melanoma is a malignant tumor whose incidence is increasing, which can develop on a site of acquired melanosis or on healthy conjunctiva, found in adults around 60, often unilateral, with a rapid raise and a rapid vascularization. Often limbic, but also on bulbar conjunctiva, cul-de-sac, or caruncle. Extension towards the cornea is possible. Here are some other slides, some other pictures about different location of conjunctival melanomas. What about the treatment? Well, carrying out documentation with taking photographs, the first step. No biopsy due to the risk of dissemination, and especially no subconjunctival infiltration. If we have to do something, we have to do it under a general anesthesia. And the excision in one piece with a safety margins, and I mean by safety margins a few millimeters. And we have to change our instrument for the reconstruction. Adjuvant therapy, it's always mandatory, and usually proton therapy is used. Risk factors are the location of the cul-de-sac, the caruncle, or a tumor thickness greater than 2 millimeters. In general, it's also necessary to look after the lymph nodes area and to consider the extension assessment with a liver ultrasound, PET scan, and what about the sentinel lymph node procedure? It remains debated and controversial. We will now talk about uveal melanomas, which are the most frequent intraocular tumors. The incidence is estimated at 6-10 cases per million inhabitants per year, and choroidal melanoma are the most frequent by far. Iris melanomas represent approximately 5% of uveal melanomas and result in an iris mass, as you can see here, which can lead to an iris bump with a pupillary deformation, or ectropion, we say ectropion of the uvea in here, but it's depending on the location. And always depending on the location, the iridocorneal angle can be invaded, like in here, and that may lead to an intraocular hypertension. As always, documentation by taking photographs is essential. A clinical examination with gonioscopy and additional examination with UBM ultrasound and OCT of the anterior segment are necessary. Here we have an example about the tumor and the UBM corresponding images. And here is another one. And with the UBM, we can carrying out millimeter measurements. The treatment of iris melanomas is depending on the size of the tumor of the initial lesion and the extent or not of the tumor. Proton therapy is essential for the limited form, and we have usually good results and rare recurrences. But we have to consider sometimes enucleation in advanced forms. Here is an example of an iris melanoma seen in 2018. treated by proton therapy. We can see here the clips used for radiotherapy. There's 3 or 4 around the tumor. And here we are in 2023. Patient is doing well and has full vision. Let's talk now about the choroidal melanoma. Choroidal melanomas are not that rare. There are approximately 500 to 600 new cases per year in France. Well, sun exposure has been mentioned as a risk factor, not in certain way, but more certainly with haute nevus. Average age of discovery is around 60. Diagnosis is severe, and metastatic evolution is significant. Circumstances of discovery are variable, either during a systematic examination of the fundus eye for other pathologies, but sometimes, and depending on the location, we can note symptoms such as reduced visual acuity, amputation of visual field, or even myodesopsia. Usually we find an orange-yellow tumor mass with pigment on the surface and more or less thick. Additional examination, here's another example here, and a very big one here with a retinal detachment seen in here. Additional examination will clarify the diagnosis with using fluorescein angiography with progressive diffusion. We usually talk about the pinpoints, like in here, and other exam as a B-mode ultrasound echography will show the shadow effect and will allow determining the thickness of the tumor. MRI, CT scan can help for the diagnosis and will give us an idea about extrascleral extension or forward the optic nerve. It is useful to discuss the signs of suspicion of a choroidal melanoma when faced with a choroidal nevus. In case of a visual disturbances, a serous detachment, a thickness up to 2 millimeters, and a big diameter, up to 7 millimeters. And we have a technical phrase to help us to discuss the diagnosis and to think about the diagnosis. And the phrase is to find small ocular melanoma doing imaging, the T for the thickness. So if we have a nevus with a thickness up to 2 millimeters, F for the fluid, the serous detachment, for example, S for the symptoms, visual acuity, amputation of the visual field, O for orange pigment, as you can see here in the slide, the orange pigments on the tumor, M for the margin, and DI for the diameter up to 7 millimeters. So how to manage choroidal melanoma? It depends, of course, on the TNM classification, and it goes from proton therapy to brachytherapy and sometimes to enucleation. So before treatment and in order to establish TNM classification, we have to do a complete ophthalmologic examination and some other exam as echography, OCT, fluorescein angiography, and other exam, MRI, CT scan. And then we use usually the TNM-8 classification based on the American Joint Committee on Cancer, and then we discuss the treatments, and we usually choose the proton therapy, which is the best option when it is possible for the small tumor, because it is possible to have a visual conservation according to the initial location of the tumor and an excellent control rate on small tumors. On the other hand, for the large tumor T4, radiation is not recommended because of the measure of complication post-treatment, and we have to consider surgery, sometimes enucleation, but sometimes a very, very big and hard surgery, which is exenteration. And for the T2 and T3, so we have to discuss on a case-by-case basis. The greater the tumor volume, the greater the risk of complication. So in conclusion, melanomas of the eye represent an uncommon diagnosis, but with sometimes significant therapeutic consequences. This pathology could sometimes involve the visual function and sometimes life prognosis. So we have to be careful and do not confuse nevus and melanoma. Documentation is always necessary, taking photographs. Please, no biopsy for conjunctival melanoma, no infiltration, because the risk of the dissemination, and the surgery is always done under general anesthesia. Radiotherapy, we have to consider this treatment, and especially proton therapy. It's always the first treatment each time when it is possible. And of course, we have to consider multidisciplinary consultation meeting, which is obligatory in France. I base myself on the latest report from the French Ophthalmology Society to prepare these topics. Thanks for listening.
Thank you very much, Toufic. It was a beautiful presentation. It's not usual to have an ophthalmology surgeon speaking during ESSO meeting or webinar, and I am very pleased to welcome you again because it's very important to see the different way and the different approach of melanoma depending of the localization.
Of course.
If you are okay, we are going to move to the next presentation and speak, if necessary, at the end of the webinar. The next presentation will be done by Dr. Elisabetta Pennacchioli, coming from Milano and the European Tumor Center. I don't remind. And she will speak about gynaecologic and digestive melanoma. And you will see it's very impressionant.
Yeah.
Thank you very much, Elisabetta.
Thank you, Gilles. Thank you so much for the invitation, and I'm very happy to share the webinar with all of you. And my talk will focus on gynaecological and digestive melanoma. I have no disclosure. Mucosal melanoma generally arises from the mucosal epithelium lining the genitourinary, alimentary, and respiratory tracts, all of which contain melanocytes. It has distinct epidemiologic etiology and clinical features that differentiate completely it from cutaneous melanoma. And this is very important for patients management. Mucosal melanomas represents around 1.3% of all melanoma, and different from cutaneous, the incidence of mucosal has remained stable over time. It arises primarily in the head and neck, in the anorectal and vulvovaginal regions, with 55, 24, and 18% of cases respectively. And rare sites of origin include the urinary tract, the gallbladder, and the small intestine. Patients are usually quite old, around median age of 70 years, which is quite different from mucosal melanomas arising in the head and neck. It's more common in females, but this is primarily due to the development of the disease in the genital tract. The incidence of mucosal is similar for white and Hispanic person, while among black persons, the incidence is approximately 2/3 that's seen in white person. And actually, it also comprises up to 25% of all melanomas in the Chinese population, 9% in black or Hispanic, and less than 2% in the non-Hispanic white persons. And it was hypothesized that melanocytes may be localized to mucosal tissue due to errors of migration from the neural crest during embryogenesis. But actually, recently, it was evident that mucosal melanocytes might have biological functions beside pigment productions. Specifically, since the mucosa plays an important role in the innate immune defense system, it was speculated that mucosal melanocytes may be equipped with immunogenic functions. In cross-cutaneous melanoma, etiology, risk factors, and pathogenesis of mucosal melanoma are fully understood, which maybe explains the deficiency of effective treatment. Obviously, the anatomic location precludes ultraviolet exposure as a risk factor, but epidemiological studies suggest that the chronic inflammatory disease, viral infections, as well as chemical irritants are maybe implicated in vulvar melanoma, and that HIV infection is associated with anorectal mucosal melanoma. Mucosal melanoma has a more diverse mutation patterns with fewer targetable mutations compared to cutaneous. BRAF and NRAF mutation, which are widely present in cutaneous melanoma, are less frequent in mucosal, while activating mutation in a KIT and loss of CDKN2A are more common in mucosal. And again, unlike cutaneous, a precursor lesion in mucosal is very uncommon, less than 10%. And the histological appearance is a kind of broad lentiginous growth pattern in the early radial growth phase, which is characterized by proliferation of atypical melanocytes in the base of the mucosal epithelium. It is estimated that 20% of mucosal melanomas are multifocal, compared to less than 5% of those arising in the skin. Approximately 40% of mucosal melanomas are amelanotic, compared with less than 10% in the cutaneous counterpart. Actually, mucosal are quite thick at diagnosis, and this is probably due to late recognition, lack of a dermal junction, but also a kind of intrinsic aggressive behavior of these lesions. They are more likely to present with metastatic disease at time of diagnosis. This happens in 23% of cases versus 5% for melanoma of the skin. And we see now something about vulvovaginal melanoma. It usually occurs in the vulva or in the vagina, and in 95 versus 3% respectively. Vulvar melanomas represent 10% of all malignant tumors involving the vulva, and less than 1% of all melanomas. They commonly present asymptomatic, but when symptoms are present, pruritus, vaginal bleeding, or vaginal discharge, as well as dyspareunia, are present. Lesions arising in the hair-bearing skin are usually pigmented and flat, while those more medially located are elevated and are melanotic. The most of vaginal melanomas are located in the lower third of the anterior wall. Approximately 70% of patients present with clinically localized disease, although the tumor is often quite thick at presentation around 4 millimeters as immediate. 20% have inguinal node involvement at presentation, and a small proportion of cases are metastatic at presentation. The largest multi-site series of vulvar melanoma, the AJCC staging system for cutaneous, appeared to be applicable to primary vulvar melanoma, and factors to be independently predictive of outcome included tumor thickness, ulceration, the number of lymph node metastases, and the site of distant metastasis. For consonant vaginal melanoma, the 5-year overall survival is around 20%, which is quite. Regardless of the primary site, initial management for local regionally confined mucosal melanoma is complete wide local resection. If feasible, complete resection offers the better chance for prolonged disease-free survival. However, complete resection with optimal margin may be difficult. This is related to the kind of lentiginous growth associated with mucosal melanoma, but also with multifocality and with obviously anatomic constraints. And today we know that it is very important to balance the morbidity of an aggressive resection against the risk of metastatic disease. That's the most of the patient will ultimately develop distant metastasis despite adequate local disease control. For this reason, the local treatment has evolved from radical bilateral vulvectomy to more individualized patient. And in this review, no difference in outcome was found between radical vulvectomy, simple vulvectomy, or wide local excision. In a study of nearly 300 patients with lesion thinner than 2 millimeters, the recurrence rate was 1.8%, as was not affected by margins of 1 to 2 centimeters versus 5. And this is very important for choosing the kind of resection that I want to underline, as today the wide excision has replaced major resection like pelvic exenteration. And also there is no need to associate lymphadenectomy. It is difficult to understand which is the best quality for the resection margin, but certainly for melanomas that are thinner than 1 millimeter, 1 centimeter of margin is enough. For thicker melanomas, maybe a wider margin is better. And the excision contains the skin, the subcutaneous tissue, it goes to the muscular factor. In the past, immunofemoral lymphadenectomy used to be associated with vulvectomy. Today, it is abandoned, as I said, but actually the sentinel node biopsy has a role. It has been largely debated, but now we know it is technically easily feasible, and the role is to identify patients for adjuvant systemic treatment. Instantly, for head and neck melanoma, due to the lymphatic anatomy, thick melanoma or melanoma near the midline may have a bilateral sentinel node or a contralateral sentinel node. And also in vaginal melanoma, wide excision is recommended. So exenteration is not recommended because of the poor prognosis and the high risk to develop a metastatic disease. So the morbidity and the reduction in quality of life, which is associated with the major exenterative surgical procedure, is probably not justified given the poor outcome. And let's take a look to systemic treatment. Unlike cutaneous melanoma, very few adjuvant studies are available. The first one was conducted by Lionnel, and it was a phase 2 trial with nearly 200 patients. They found no statistically significant improvement in relapse-free survival for temozolomide plus cisplatin compared to high-dose interferon and observation. And but actually, despite the result of the trial, the consensus of the expert panel at the ASCO found that these results are so far from results we are obtaining in cutaneous melanoma that they do not recommend chemotherapy, as probably other therapies might be superior. There are other trials reporting on a little series of mucosal melanoma, but these subgroup analyses are so small to be considered not relevant. And in Checkmate 238, 27 patients with mucosal melanoma were included, but the analysis was not able to establish any difference in relapse-free survival between ipilimumab and nivolumab. So today, patients with mucosal melanoma may be offered the same therapies recommended for cutaneous melanoma in absence of relevant studies, not thanks to relevant studies. And in this consensus that I already mentioned, it was also analyzed the small non-randomized phase 2 study that suggested that KIT-positive mucosal melanoma may be responsive to imatinib. But the panel, due to the limited evidence, doesn't recommend KIT inhibitors. But we may think about the fact that it does exist. And this is the first randomized trial comparing the therapeutic effect of an anti-PD-1 antibody with high-dose interferon. The results demonstrated no statistical differences in relapse-free survival, overall survival, or distant metastasis-free survival between toripalimab and high-dose interferon. But the study is anyway important because it shows more safe and tolerable profiles for toripalimab, and also because this kind of study will probably lead to future clinical trials in which anti-PD-1 antibodies monotherapy arm can be used as the control arm to compare with other novel adjuvant therapies. However, further evidence is required to fully accept that PD-1 antibody should be set as a standard of care in mucosal melanoma. And this table summarizes a study for anti-PD-1 monotherapy in advanced mucosal melanoma. They reported that the therapeutic effect of PD-1 antibody is much lower than that seen in patients with cutaneous melanoma. And this may be related to the lower mutational rate of BRAF, the lower mutational burden, and the high rate of copy number alteration. And these are a list of trials that are ongoing and are investigating the effect of various agents in combination with anti-PD-1 in mucosal melanoma. This kind of combination targets different cancer immunity cycles, so maybe will be more promising for mucosal melanoma. But I wanted to share with you this interesting experience from Japan of carbon-ion radiotherapy in gynecological melanoma. We know that photon radiotherapy was not able to achieve complete responses because of the radioresistance inherent with gynecological melanomas. On the other hand, in this study, it was demonstrated a favorable local effect with 81% of patients who achieved a complete response after radiation. The 2-year local control, overall survival, and progression-free survival were 71, 53, and 29% respectively. So we know that the standard of treatment is surgery, but actually with surgery, the rate of local recurrence is up to 40–60% of patients. And also that such treatment may incur in post-operative physical and functional disabilities. So carbon-ion radiotherapy has been suggested from these colleagues, worthy of consideration as a local therapy and even as a definitive treatment option for patients with mucosal melanoma. And here we have another experience, the ICONIC, which is a multi-center, open-label, non-randomized phase 2 trial, which assessed the feasibility and clinical activity of the association of carbon ion radiotherapy with immune checkpoint inhibition. It was in patients who obtained a stability with pembro received a standard of care. And this is another experience which is ongoing at now Milan, is a monocentric prospective phase 2 study. Patients with primary gynecological melanoma, not metastatic, not suitable for surgery, and not previously subjected to conventional radiotherapy can be enrolled. After carbon ion radiation, the patient receives immunotherapy, not concomitant. And the response is evaluated through RECIST criteria. And we know that early results are promising. And we move now to digestive melanoma, differentiating between anorectal and gastrointestinal tract melanoma. Anorectal melanoma may arise in the lower rectum, anal canal, and perianal skin. It accounts for 0.5% of all colorectal malignancies and 1% of all anal canal cancers. Also, although the risk factors are not known, epidemiological data suggest that there is an increased risk associated with HIV infection. It is typical for older persons with a median onset at 60s, with a slight male preponderance. Typically, patients present with bleeding or with a mass or with anorectal pain. And the initial staging, as for all the other disease, should include a rectal examination and a rectal ultrasound, and then a CT scan or a PET scan for the assessment of distant disease. Prognostic factors include larger tumor size, increased tumor thickness, perineural invasion, the lymph node involvement, and the presence of amelanotic melanoma, which is very typical in the rectum. These are the expected survival. The classification is just on 3 stages, and the 5-year overall survival is 26 for localized disease, but 0% for metastatic disease. The primary goal of surgery is to perform a negative margin, possibly a sphincter-sparing excision, as even if historically the standard was abdominal perineal resection, but multiple studies, which are retrospective, which are small in size and collected over many years, but all of them report similar survivors for both the abdominal peritoneal resection and sphincter preserving wide local excision. The margin of excision is not well described, but an R0 resection with 1 centimeter margin is associated with a reduced risk for local recurrence. And retrospective data suggest also in this case there is no difference in overall survival with more conservative wide local excision, and that the benefit of improved local control upon survival is limited. And this is related to the high risk for distant spreading. Today, abdominal perineal resection is reserved for patients with bulky local disease and also for carefully selected patients with local recurrence. Lymph node status is an important prognostic factor, but lymphadenectomy doesn't play any role and is not recommended, while sentinel node has the same role as in all the other melanomas for staging of the disease and selection for adjuvant treatment. So the most important factor for surgery is to that the margin is negative, and in this multivariate analysis, the resection status and tumor stage were significantly associated with prognosis, but the type of resection also here was not significant. Concerning gastrointestinal tract as a site of metastatic disease, I think that different considerations need to be taken. Actually, before immunotherapy, 5-year overall survival rates were between 30 and 40% in metastatic disease in the abdomen. But with the development of effective targeted and checkpoint blockade drugs, we are observing long-term overall survival of over 50% beyond 5 years for metastatic patients. This obviously raises the question of whether surgery has a new role for patients with metastatic melanoma. Actually, some, even if not all patients, may benefit from surgery to render them disease-free, as metastasectomy may decrease the tumoral burden. This makes the systemic agents more effective. And actually also adoptive cell therapy represents a new shift in highly personalized therapy. And the surgeon has a role in this kind of treatment as the surgeon assists with resection of metastases for TIL harvest. The best TIL targets are those that can be safely resected with minimal risk of complication, so that the patient can undergo the aggressive immunoablative regimen necessary for TIL infusion and for expansion. And this is a very old study which refers to patients observed between 1970 to 2014. It was something like 600 patients with a median overall survival after metastasectomy of digestive metastasis that was significantly better than for metastases located in other sites. And this patient could achieve a median survival of 64 months. And this is important because this opens the options to treat digestive metastatic locations. And there is a role also as for palliation, which is the palliation of symptoms, which can be obtained in about 80 to 100% of patients. Obviously, it's very important to select patients for resection in this who are metastatic patients, and we made a kind of tentative to identify factors to select patients in different senses, like the oligometastatic disease, the isolated progression, the indolent disease, and palliation. And what do we look to? We take into account the quality of response to systemic treatment. Patients who do not respond have no advantage from resection. The disease-free interval, which can use the tumor doubling time. The number of metastatic sites, so no more than 3 sites should be resected. And the possibility to obtain a complete resection of all the metastatic disease. So as this was a kind of an overview, I haven't got a conclusion slide, but I thank all of you for your attention. And I will take any question.
Thank you very much, Elisabetta, for this very large presentation. And I think that we have to move on. You have to answer, you have some question here you can see on your screen. You have a specific question about vulvar melanoma and nodes management. I engage you to answer it if it's possible. You see it? In fact, the 3 question is only 1.
You okay. Think I can write while we are on?
If you click on we'll do after. We move on to the next presentation. Okay. Dr. Emilie Beulque is a head and neck surgeon in our institution, and she's going to talk about head and neck mucosal melanoma.
Yes.
So, Emilie, thank you very much.
Yes. Hello, everybody. So, like you said, we'll talk about head and neck mucosal melanoma. So, the mucosal melanoma is a rare pathology. We said it before. There is more women than men, and the average age is 65 years old. I didn't find it's the same frequency in all ethnic origin in head and neck, and the risk factors and etiology are not as well established as UV exposure, like cutaneous melanoma in head and neck. So head and neck is the most common site. You have sinonasal site and oral cavity, which are the more common. The origin, so the melanocytes, you can find them in all tissues. They are in the basal cell layer of epithelium, even in the not pigmented epithelium. There's a bad prognosis due to a late diagnosis because it's often an occult anatomic site. Half lesions are amelanotic, and 20% patients have metastasis and lymph nodes at diagnosis. The 5-year survival rate is under 20%. And the common metastatic sites are regional lymph nodes, lung, liver, and distant nodes. So we'll talk first about sinonasal melanoma. You have nasal cavity and the sinus site. For the nasal cavity, it happens often on the nasal septum, mostly on the inferior part, and on the nasal wall, just in between the origin of the turbinate, the inferior turbinate or the medium turbinate. And for the sinus, the common site is the maxillary sinus. In the nasal cavity, the diagnosis is easier because you can see it just in the examination. But for the sinus melanoma, for a long time, it's asymptomatic before adjacent invasion, like invasion of the bone or the eye. So there is a more advanced stage at diagnosis for the sinus melanoma. And so there is a better overall survival for nasal cavity melanoma because of this easier diagnosis. And the first symptom in head and neck can be the lymph node. It's the first symptom that you can see. For the sinonasal melanoma, at the clinical examination, it's the same symptoms as for current pathology of sinuses. So you have a unilateral nasal obstruction, epistaxis, rhinorrhea, or hyposmia. You have to do a nasal endoscopy, of course, to see the lesion. You have also to do the lymph node examination. And don't forget to search oculomotor disorders and to ask patients if he has diplopia. And it's really important, don't hesitate to ask dermatologic examination because the lesion in head and neck could be a metastatic cutaneous metastasis of a cutaneous melanoma. So here we can see an example of a pigmented lesion. So it's just on the in between the lateral wall and the origin of the turbinate. For the oral cavity melanoma, so it's 30% of mucosal melanoma, mostly on the palate and on the maxillary gingiva. Often it's asymptomatic, and the diagnosis is easier, but be careful, the lesion can be amelanotic. And there is more lymph node metastasis at the diagnosis than pseudonasal melanoma. So for the clinical examination, the same, you do the nasal endoscopy because you have to search another lesion on the upper aerodigestive tract. You search lymph nodes, of course, and don't forget dermatologic examination. So here we have an example of a pigmented lesion on the left palate here, with another pigmented lesion just here. So after the examination, you do, of course, the biopsy with the pathology examination for the cell themselves. You search immunohistochemical strain against protein S100, HMB45, Melan A, and MAT1. It can help for the diagnosis. And if you can, ask for the search of BRAF and ARAS mutation. I found there is less mutation in mucosal melanoma than cutaneous melanoma, but it's important, I think, for the treatment. Then you have to do also imaging, so a CT scan, an MRI, to see if the lesion is extended to the bone, and a PET CT scan to search metastasis and lymph nodes. So here there is an example of a patient who has a lesion in the sinonasal here cavity, which extend in the upper side to the frontal sinus. And sorry, you can see the same patient with the TEP scanner, and you can see, sorry, it doesn't work. Yes, and you can see the same lesion in the TEP scanner. And so there is no specific staging in head and neck for the mucosal melanoma, but I think we can use the 8th edition for the cutaneous melanoma. It can help for the treatment, and so it's just for it's showing you the difference between the 7th edition. For example, for the lymph node, now you have to see if it's clinically occult lymph node or clinically detected, for example. And for the metastasis, there is non-differences with the metastasis to the brain. For the treatment, first, if you can, of course, you can do surgery. You have to do a local surgery with margin adapted to the anatomic site. It's better to have a complete surgical excision with 1 or 2 centimeters margin. And you can use, if possible, endoscopic surgery or robotic surgery. It's interesting in head and neck to use reconstructive surgery because of the swallowing, for example. And we use in our center a free flap reconstructive surgery. So we use antebrachial free flap or anterolateral tight free flap. And there is also here an example of using indocyanine green fluorescent. And here you can see the flap with a good vascularization after the anastomosis. Again, the surgery for the cervical lymph node dissection is important. You do it if there is clinical positive lymph node. In the literature, sentinel lymph node did not show an improved overall survival, but you can discuss it in the multidisciplinary meeting if the method is available in your center. And you can see here a fluorescent lymph node in a cervical lymph node dissection. For the complementary treatment, radiotherapy, of course, to improve local control, but not overall survival, or you can use it in case of a non-resectable tumor. And immunotherapy and targeted therapy. Dr. Geoffrois will talk about it just after me. So the take-home message is, so it's a rare lesion, but you have to think about it. It's a worse prognosis with metastasis at diagnosis and lower survival rate than cutaneous melanoma. And it has to be known to improve early diagnosis. For now, it's the same treatment than cutaneous melanoma, but maybe it will change with the evolution of immunotherapy. And if you can, it needs at first surgical treatment if possible. Thank you.
Thank you very much, Emilie, for this speech. With the 3 surgical speech are spectacular. We can see there is a necessity of surgical skill different with the specialty, but it's not so easy to remove those kind of tumor, and the prognostic have to be improved, and maybe with and surely our experience with medical treatment. And Lionnel Geoffrois, medical oncologist, specialized in dermatologic tumors and specialist of melanoma as well, is going to talk to us about the biology and medical treatment that we can add to the surgical treatment. Thank you, Lionnel, for your presence.
So thank you, Gilles, for the kind introduction, and thank you for the invitation. Did you see my slide?
Yes.
Okay. So I think you wanted to challenge me to speak about non-cutaneous melanoma and genetic specificity and medical treatments in 15 minutes. So I'm going to try to do it as well as I can. I will talk only about treatment of advanced disease, mainly metastatic disease, because actually for non-cutaneous melanoma, there is no recognized treatment in adjuvant situation. So if you want to do adjuvant treatment, put your patient in a clinical trial, but don't do it as a routine treatment. There is no routine using of adjuvant treatment in non-cutaneous melanoma. So these are my disclosures. As you heard before, melanomas are different if they are from cutaneous origin, mucosal origin, or from the eye. And because they are all melanomas, but they are all different, they have not the same biology and they have not the same prognosis. Cutaneous melanoma is characterized by its own carcinogenesis due to UV exposure, and it's characterized by a high tumor mutation burden and a high rate of BRAF mutation. About 50% of cutaneous melanoma do carry BRAF mutations, mainly BRAF V600. And this tumor are highly sensitive to ICB, to immune checkpoint blockers, and to BRAF MEK inhibitors. Mucosal melanoma, you heard about the epidemiology. It's a rare tumor. The predominant anatomic site is head and neck. The risk factors is not well defined, and there is non-UV exposure. The median age is higher than patient for cutaneous melanoma. It's about 70. And there's a geographical repartition, and it's more frequent in Asia and less in Western world with Caucasian people. The incidence of mucosal melanoma remains stable. In cutaneous melanoma, it's increasing very rapidly. The molecular biology of mucosal melanoma is really different from the molecular biology of cutaneous melanoma. And this is due to the carcinogenesis and mainly to the UV exposure. And you see here in this scheme that cutaneous melanoma have a high tumor mutation burden, and other melanoma from mucosal or from the for the uveal melanoma, they have a low tumor mutation burden. There could be the explanation. This is one of the explanation of why it's less sensitive to immunotherapy. So the challenge actually is to search for biology and then find the treatment. Molecular biology in mucosal melanoma, there is a few things that we can note and that can help for future treatments. First time, there is amplification and mutation in KIT oncogene. It's an oncogene that you can find in GIST tumor, and it's about 1/3 of patients with cutaneous melanoma that have KIT mutation. They are encoded by exon 11 or exon 12 or 21. It's missense mutations or amplification. The second one is SF3B1. It's present in about 1/3 of mucosal melanoma, mainly anorectal and vulvovaginal. We are going to see that the molecular biology is really different in mucosal melanoma for patients who had mucosal melanoma from the upper region of the body or of the lower region of the body. SPRID1 and NF1, they are negative regulators of MAP kinase pathways, and we do have some therapeutics that targets these pathways. They have negative factors, and they have an important role in progression of the tumor. Here in the TCGA, it's the Cancer Genome Atlas. We can see the mutation that we can find in the mucosal melanoma. As I said before, in upper part region of the body or in lower part region of the body, it's a bit different, and it's very different from cutaneous melanoma that you can find in the B figure of the scheme. If you find a target, the challenge is to find a therapeutic target, and there are quite a lot of targets in mucosal melanoma, but if we challenge it with the therapeutics that we have now, it's a little bit disappointing. The prognosis of the metastatic mucosal melanoma is really bad. It's really poorer than cutaneous melanoma. It's often tumors that are really advanced at the diagnosis because the diagnosis is often delayed. It's amelanotic in 1/3 of the case, and the survival for patients with metastatic mucosal melanoma is about 12 months or less. You heard about the primary treatment of the primary tumor, and for advanced tumors, it's mainly medical treatments. I will talk about immunotherapy with immune checkpoint blockers. The results are disappointing if you compare it to the treatment of cutaneous melanoma. There is no large studies and only a few number of patients from large studies, mainly with patients with cutaneous melanoma. ICB is anti-CTLA-4 alone or anti-PD-1 alone or anti-CTLA-4 plus anti-PD-1 combination. If you take anti-CTLA-4 ipilimumab, the response rate, is really low. It's about 10%, and the median overall survival is 6 months in these two studies with small numbers of patients, 33 and 77. If you take anti-PD-1, There is a post-hoc analysis of 3 big studies with Keynote 001, 002, 006, with 84 patients who had mucosal melanoma, and the overall response rate is 22 months. Median PFS is 2.8 months, and median OS is less than 1 year, 11 months. It's about the same with nivolumab, another anti-PD-1. And here, a prospective study with 44 patients who received ipilimumab or pembrolizumab, an anti-PD-1. It seems to look a bit better with anti-PD-1, but it's still really disappointing, and the overall survival is still about 10 to 12 months. Using a combination of anti-CTLA-4 and anti-PD-1 could be better. This is a pooled analysis of 86 patients. The response rate is a bit higher, 37%, and overall survival in the second study is better than it was for monotherapy. And a retrospective analysis from the MD Anderson with more than 200 patients seems to prove that it can be interesting for patients to receive this kind of treatment. So if it's feasible for the patient and if there is no contraindication, the combo therapy with anti-CTLA-4 and anti-PD-1 is preferred. I will show you 2 short clinical cases. This one is a man of 64 years in 2020, mucosal melanoma from nasal cavity, proven by biopsy, BRAF wild type, CT scan MRI, big tumor from the right nasal cavity, and he had liver metastasis at the diagnosis. We proved it by biopsy on the liver, and it was metastasis from the melanoma. So we start on with ipilimumab and nivolumab, 4 courses. That's the usual scheme, 4 courses, and then maintenance therapy with nivolumab. He received 4 courses, and he was in CR after the 4 courses. He received a maintenance therapy with nivolumab until May 2023, and then we stopped because he was still in CR. He had the toxicity of hypophysitis, but his long-term lasting CR, no recurrence. Just a quick remark, he had hypophysitis, so he needs to receive treatment for hypothyroidism and adrenal gland insufficiency at life. So this type of treatment could be efficacious, but it's sometimes toxic. This kind of toxicity is really usual. The second case is a woman of 47 years old. She had surgery for a mucosal melanoma from nasal cavity. She was planned to receive radiotherapy as adjuvant treatment, and then she developed neurological disorder with ocular mobility abnormalities. On the CT scan, we saw a recurrence. On TEP CT, we saw also a local recurrence, and she had a left ovarian metastasis. So we treated her with this combination, the same 4 courses, and then she had CR. She remained on maintenance, but we stopped because she developed grade 3/4 hepatitis due to the treatment, and she's still in CR 1.5 years after the end of the treatment. So it could be efficacious, but it's quite toxic. But there is no other available treatment actually. Other immunotherapy, biochemotherapy, it's chemotherapy with high dose cytokines. A new form of IL-2 is nemvaleukin, who is actually developed in clinical trials. Cell therapy as using TIL or CAR T cell. It's only on early phase of clinical trial. We developed, we saw just before that there is a lot of targets that we can look if the therapeutic targets are efficacious. So the problem is that the results are really disappointing actually. The KIT inhibition, I told you before that KIT mutation is present in about 1/3 of patients. Using TKI who are active on KIT inhibition, like imatinib or nilotinib or dasatinib, the second generation of this type of molecules, it's really disappointing. The response rate is low, less than 20%. The median OS is still low, less than 12 months globally, and it's not really efficacious, actually. The BRAF/MEK inhibition, who is really active in cutaneous melanoma, BRAF mutation are only present in 8% of mucosal melanoma, and BRAF V600 it's only 63% of all mutation. It's more than 90% in cutaneous melanoma. So BRAF mutation exists in mucosal melanoma, but it's not clear whether a patient with BRAF mutation mucosal melanoma will achieve similar response. And there is only small studies, one here with only 12 patients. The response rate is 20%. In cutaneous melanoma, the response rate is more than 3/4 of the patient, and the median OS is 8 months. So BRAF/MEK inhibition is a keystone for cutaneous melanoma, but not for mucosal melanoma. So the recommendation are for metastatic patient to use first immunotherapy if the patient is in condition to receive it. Do molecular biology to find a target and then propose it as a targeted therapy after having reviewed the case of the patient in molecular board. But the preferred proposal will be to find a clinical trial for your patient if you have so. The uveal melanoma, we heard about it previously. It's also different. It's a rare disease, and in 15% of the cases, the patient will develop metastasis. And the main site of metastasis is liver. In 19% of cases, there is liver metastasis. Often, it's the only site of metastasis. The 5-year survival for all stages is between 50 and 70%. But if you have metastatic disease of this kind of tumor, the median overall survival is between 6 to 12 months, and 8% of patients will survive more than 2 years. There are quite a lot of mutation also in the uveal melanoma. The main is the GNRQ and the GNA11 mutation. They are encoding for a protein within the MAP kinase pathway. And this mutation are interacting with MAP kinase pathway and upregulate the PI3K AKT signaling pathway. It's the usual signaling pathway that we are targeting with TKI therapy. There are also this mutation interact with cell proliferation, inhibition of apoptosis, process of cell survival. BAP1 mutation is another mutation that is located on chromosome 3. It's encoding for BRCA mutation that you heard about it probably in breast cancer. It's inactivated in 84% of patients, and the loss of BAP1 function is implicated in a regression of melanocytes to a dedifferentiation states and the pro-metastatic behavior. And there are also quite a lot of chromosome alteration in different chromosome on 1p, 6q, 6p, etc., etc. Immunotherapy for the metastatic uveal melanoma, it's more and more disappointing than it was for mucosal melanoma. The response rate of anti-CTLA-4, anti-PD-1, or the combo anti-CTLA-4 and anti-PD-1 is very, very low, less than 10% in monotherapy, and about 13%. And the median overall survival is also about 1 year. There is a very low efficacy of ICB in metastatic uveal melanoma. The main reasons are the location of the tumor in the eye. There is no lymphatic structure in the eye, and there is no proliferation of lymphocytes, as you can see in cutaneous melanoma. There is a low tumor mutational burden, and there is a high expression of immunosuppressive proteins like IDO1 or LAG3. There are ongoing trials that are using anti-LAG3 like relatlimab, which has been used in the cutaneous melanoma with anti-PD-1, and relatlimab with the vaccine. There are some ongoing trials. So immunotherapy is not doing better than chemotherapy, and there is a lot of disappointing results and very, very bad prognosis for these patients. These are all the immunotherapy trials that you can find in the literature with the metastatic uveal melanoma, and there is no really a good option, but there is no other treatment. So the other treatment came 1.5 to 2 years ago with a new treatment, is tebentafusp. Tebentafusp is a bispecific monoclonal antibody. It's a GP100 peptide highly expressed in the uveal melanoma cells, and this molecule is a T-cell receptor bispecific fusion protein that targets the GP100 and CD3, and it's redirect the T cells to kill GP100 positive melanoma cells, and it's only for patients that are HLA-A0201, and so it's restricted to this group of patients. So if you want to give this treatment to the patient, you need to screen for HLA first. It's approved in metastatic uveal melanoma since last year in Europe, also in France, and I think in most of European countries. This is the result of a phase 3 study for patients with metastatic uveal melanoma who are HLA-A0201 positive, and they receive either tebentafusp in an increasing dose, and because of the toxicity, 20 microgram first day, 30 micrograms the day 8, and then 68 micrograms every week. And it was compared to investigator choice. I told you just before that there is no real standard treatment in first line, so you can use chemotherapy like dacarbazine or ipilimumab anti-CTLA-4 or pembrolizumab anti-PD-1. The population in both groups were well balanced, and the first result demonstrated better overall survival at 1 year with tebentafusp, 73.2% versus 58.5%. And the result published in last December confirmed that there is an increase of overall survival with the use of tebentafusp, with a reduced risk of death by 32% and a reduced risk of recurrence of 24%. Interestingly, there is a 100 days landmark analysis that demonstrated that patients who had as best response progressive disease had longer survival if they received tebentafusp. That means that even the patient doesn't respond to the treatment, even if the tumor doesn't shrink, you can prolong the survival of the patient with using of this treatment. I think it's the first time that we saw this type of consideration. So So the response rate is low. It's about 11% in the tebentafusp group versus 5% in the control group. Stable disease is 35%, but as I told you just before, the patient, even if they have progressive disease, they can achieve longer survival with this type of treatment. Interestingly, if the patient had undetectable ctDNA at baseline, it's a prognostic factor, and they have longer overall survival if you don't find any ctDNA in the blood. So the liquid biopsy could be good prognostic factors in this type of situation. It's a treatment that is there is a low rate of toxicity of grade 3-4. The main toxicity is CRS. It's cytokine release syndrome. You need to the patient receive the first the 3 or 4 first administration in not in day unit but in hospitalization for surveillance, because if they have grade 3-4 CRS, you need to manage it as soon as possible. But grade 3-4 are really rare, and it's mainly grade 1-2 with rash, pyrexia, pruritus, and hypotension. And it happens only in early phase of treatment. To just complete with targeted therapy, we saw just before that there is quite a lot of mutation that you can find in uveal melanoma that you can target with therapeutic molecules, with TKI mainly, the MAP kinase pathway, the PI3K, AKT pathway, etc. There is a German study here with about 40 patients. They've done molecular biology. They found some targets, and they treat the patient with some therapeutic targets. Here we have a MEK inhibitor, ALK inhibitor, MET inhibitor, etc. Once again, the results are really disappointing. There is only a few patients that had partial response. Some patients had stable disease, but actually there is no recognized therapeutic with targeted therapy for this type of situation, and the median overall survival is still low, about 1 year. So the recommendation actually for metastatic patient with uveal melanoma is to screen it for HLA-A0201. If they are positive, treat them with tebentafusp is the recommendation actually. If they are negative, do treatment with first line anti-PD-1 or chemo, or preferably try to find a clinical trial for your patient. And after first line, do molecular biology and find a clinical trial for your patient. Thank you for your attention.
Thank you very much, Lionnel. It was a very complete panel of progress in medical treatment in non-cutaneous melanoma. I could say after this, at the end of this webinar, that when we ask questions about a problem like non-cutaneous melanoma, organize a webinar, and many gentle people will give you very good response. I see that there are different surgical approach, and non-cutaneous melanoma have not to be treated as cutaneous melanoma. The surgical principles are different with the localization, and I see that the best treatment is early diagnostic and early treatment, but I see as well that we can have hope with the medical treatment. it's not perfect, but I've seen that we have progress coming in the next year. So thank you to all of you. I wanted to say you that we had a participant up to 70 during this webinar, and still people looking to us. So thank you as well to them, and thank you for participating. And if you have any comment to add to or any question to add to my purpose, no. It's late, so thank you very much. Thank you very much, and hope to see you in a new webinar further. Goodbye.